So Dr. Sellers is an assistant professor in the Division of Cardiology at the University of British Columbia and director of the Center for Cardiovascular Translational Science at the Dilawri Cardiovascular Institute. Her research group primarily focuses on bioprosthetic valve durability as it related to molecular mechanisms of degeneration, imaging, and reintervention. The lab also works extensively on bench modeling of new interventional techniques and TAVR devices and runs a global explanted TAVR valve biobank. The author of more than 150 publications, Dr. Sellers serves on the editorial boards of Cardiovascular Pathology, Journal of the Heart Valve Society, Structural Heart, and JACC case reports. Dr. Sellers, thanks for being here today.
Thanks so much. So it's great to be here and talk with everyone today. Here are my disclosures. Just as an introduction to our lab, so we are located at St. Paul's Hospital in Vancouver and also at Vancouver General, bridging the two TAVR programs. Members of our lab include all of these different categories of people. We like to say we do science like a heart team, and we're very integrated into our valve program here in Vancouver. And that allows us to provide a lot of different services and really run a translational valve program that informs patient care, but also informs basic science. And so today, you guys gently asked me to talk about valve degeneration as it relates to different forms of thrombus formation, degenerative states of these valves, how we look at this from a translational perspective in terms of imaging. And then I thought we would talk about some insight to why we consider understanding this pathology important to understand durability and improving durability, but also for reintervention. And so the reason that we're able to do a lot of this work is we run a global explanted valve registry. Michigan, in particular, SAMICI is a very big contributor to this registry, and that tells us that we have all these different types of explanted valves over the last 20 years, including Dr. Webb's very first transfemoral TAVR valve. And so we're able to look at these patterns of degeneration over time. And so what you see here is that degeneration of these valves is very heterogeneous. And this is a very difficult problem to solve and start to piece together, and really trying to ask ourselves the question of why do we get these different degenerative states? What are the key common features? How do we image these and understand how to prevent some of these things, but also overcome the challenges they pose to reintervention or in forms of redo TAVR or explant. And so really, when we look at the literature, you can look up bioprosthetic valve degeneration and you'll get a nice diagram like this that is very informed by a lot of different forms of staining and enzymatic assays. But what I would point out is that these diagrams are a summary of mostly valve data over the last 60 years. And a lot of these pathways haven't been confirmed. And to some extent, some of them have been shown to be slightly different in transcatheter valves as well. And so really our group looks at trying to identify the features of current platforms of transcatheter valves. And we've done that in a number of different ways. And we try and answer this in terms of what happens that drives leaflet thickening and stenosis or regurgitation of these valves. Initially, some of the studies we did looked at what is the actual extent of leaflet thickening. Here you can see valve histological cross sections where that leaflet is approximately 3 times as thick as it normally is. So a sapien leaflet is usually about 400 microns. That leaflet there measures somewhere around 2 millimeters across, something that can significantly alter the landing zone if you're putting another valve in. And we know that leaflet thickening is progressive over time. And so we really then also want to know what is actually driving this leaflet thickening. And the key features that come across in the assessment of degenerative states of transcatheter valves are thrombus, fibrosis, and eventual calcification of these valves. And if we look across, that is what we see. This is frozen.
If you click the screen again, yep, you'll take control.
There we go. So we can do this on histology. We can do it with imaging as well. But what is interesting is that we see that this is a progressive phenomenon, meaning that in every explanted valve we look at, there is some degree of thrombus formation on this valve at the histological level. And that occurs up until 30 days. And up to after 60 days, we actually always find this thrombus in combination with fibrosis as a part of the organization process with the thrombus formation on these valves. And then up to 4 years, we always find that in combination with calcification. And so this is a progressive pathway that these valves progress through. The caveat to that being endocarditis, in which case we see calcification in those areas of infection much earlier. And so really we want to ask ourselves, within this progressive pathway, what can we learn about each of these things and prevent them or inhibit them in some way, or learn how to image them and appreciate the degenerative pathway that a particular patient is taking. And so if we look at thrombus formation, one of the questions we asked ourselves is, you know, this is the classic appearance of HALT being in Vancouver with Jonathan Leipzig and Philip Blanque. We talk about HALT and scoring on CT all the time, and really wanted to ask, is this also what we see on the actual explants we look at? And in most cases, that is also true, that at the base of that leaflet, we see the predominant accumulation of thrombus, consistent with what we see on CT. We don't see that necessarily correlates to implant duration, something that it resolves over time and reaccumulates over time, something that would be consistent with some of the leaflet thickening sub-studies at 1 year and 5 years that we're seeing, that a patient may or may not have HALT that's detectable on CT at different time periods. So really finding validation of what we're seeing on imaging of HALT on the bench as well. But what we also know is that HALT isn't, and thrombus formation isn't just one thing. It's a very complex mechanism. And really, CT doesn't allow us to appreciate the differences in the different states of thrombus and organization of this thrombus. So what you see in the bottom left-hand corner is a valve-in-valve where we have overt thrombosis on the leaflet at about 2 o'clock, mild extent of thrombus on the second leaflet, and then that third leaflet is highly mobile. So these valves we can put back in our hydrodynamic testers and start to understand how much thrombus and in what organization state causes this amount of leaflet restriction. The key is to then be able to relate that to imaging. We saw Hassan Jalawi present some of this at CRT a couple months ago using an adaptation of Dominique's autoplaque software, in which they were able to relate this to what degree of thrombus was on that leaflet and understand that more. And then we saw from Randy Ramani's group understanding the organization of this thrombus over time, really telling us that if that thrombus is there, it will organize, that starts to restrict that leaflet and change the pathology, and eventually contributes to the fibrotic processes that go on in these leaflets. And so really we want to understand more about this thrombus and how it forms. Obviously from a translational perspective, PET tracers are really our friend. It gives us a readout of what's going on in these valves. This is a project we worked with Mark Dweck's group in Edinburgh with, looking at their GP1 tracer for detection of activated platelets, in which we saw that essentially what we see on histology and on the bench as well is that every prosthetic valve had activated platelets on its surface and was to an extent forming micro amounts of thrombus, something we didn't see when this tracer was used in native valve disease, and saw, like we see on the bench, that this happens early on, and then there's less of this over time as that valve undergoes different endothelialization and fibrotic infiltration that really prevents some of that platelet activation. And really the key to this tracer was actually being able to bridge back to the bench and validate this using explanted transcatheter leaflets that had thrombosis on them, showing that really that tracer specifically binds to activated platelets on the surface of these leaflets. It doesn't bind to areas of fibrosis, which you see in the bottom panel, and then it doesn't bind to areas where of calcific leaflets as well, really allowing us to be confident in that clinically that tracer was imaging what we thought it would image. And we also found that to activated platelets derived from TAVR patients as well in cell culture assays. And so really that tells us that this thrombus formation really correlates to what we're seeing on CT. What we need to understand now is more the nuances of what stage that thrombus is in, and to what degree we're able to inhibit that to an extent where it may not be remodeling, it may not drive downstream degenerative pathways, or if that's not possible at all, and we need to target further down that pathway. And that's really become our question. And that leads us to looking at fibrosis, because we know that will be a long-term consequence of this thrombus formation, and asking what goes on there. And essentially, we know that fibrosis will remodel on these valves over time. You get remodeling of and realignment of the collagen that really stiffens that leaflet. And we also know that the formation that stiffens collagen is associated with the expression of matrix metalloproteinase enzymes. That sounds really scientific. Why is that important? We've shown in cultures that if you take a transcatheter leaflet and expose it to activated metalloproteinases, that it can actually degrade these leaflets over time. And of course, in that degraded area, you will then form inflammatory infiltrates and calcification as well, telling us that this is an important part of downstream tissue remodeling on the surface of valves that we need to be concerned with and try to start to inhibit to improve durability of these valves. We also know that fibrosis plays a role outside the valve as well. This is actually derived from an array of valves from Michigan, where we scored actual fibrotic growth and platelet activation and thrombus formation that eventually results in this kind of encapsulating of both balloon expandable evolute core valve platform and the balloon expandable sapiens and self-expanding evolutes. We did this over almost 100 valves, finding that this is a progressive phenomenon over time and significantly obstructs access to various levels of the cells. Important, obviously, in neosinus washout, could complicate, in theory, explant, and then, of course, for coronary access. So fibrosis doesn't just play a role on the valve, but around the valve as well. And something we need to understand how thrombus formation and fibrotic infiltration contribute to that. And we know that that is eventually a result of a platelet activation through a bunch of different IHC staining that we did, telling us that this is a granulation tissue event, and really something that we need to consider thrombus outside the valve as well. And so once we get past fibrosis of these valves, eventually we know that calcification comes into play. And generally that's what we think about when we think about long-term structural valve deterioration, is calcification of these valves. We know that calcification of these valves will split apart the fibrils. This is a confocal image of a calcified valve where you can see all that black in between the leaflets, pushing it apart and actually disrupting the matrix. We know this mostly comes in the form of calcium phosphate, which we can derive from microscopy. And we also know that we can detect calcification like this as an active process using PET as well. And so this was actually a trial done by Dave Newby's group in Edinburgh, again, looking at sodium fluoride PET for the prediction of degeneration of both surgical and transcatheter valves, done over the course of 2 trials, known as Fabulous and Fabulous 2. In which we see that sodium fluoride avidity was predictive of annualized change in peak velocity and was correlated to the stage of structural valve deterioration of surgical valves and of transcatheter valves. And interestingly, this bound to a lot of the things that we just talked about. It bound to degeneration of transcatheter and surgical valve leaflets, bound to areas of microcalcification, and it bound to areas of enzymatic activity where that leaflet was being degraded, telling us that this is an interesting tool for us to be able to predict degeneration of these valves and give us a readout of biologically what's going on, telling us that these pathways are leading to microcalcification and stiffening and dysfunction of these leaflets. And this is the data from the TAVR arm of this trial as well, in which we saw similar results as well, that it was predictive of annualized change in peak velocity and state of structural valve deterioration of these valves. And once again, this paper was only possible because we were able to validate binding of this tracer to different states of degeneration on the bench using explanted valves, really allowing us to understand this process. What was interesting about this trial actually was also this. Usually when we talk about imaging THVs, we're very focused on the leaflets and the expansion of the frame of the THV itself. And what popped out to us is that this sodium fluoride avidity continued to increase in the native valve post-TAVR. And what was really interesting here is that in case of explanted valves where we had retained aortic valve roots, where we could look at the native valves, we're able to show that really calcification post-TAVR out to 7 years continues to happen, and that this correlates to binding of sodium fluoride as well. And we really delve into this in a subsequent paper where we looked at what is actually occurring. So what you're seeing here is a histological cross-section of the remnant or native neosinus of the explanted TAVR valve. You can see the very straight line that would have occurred that was removed from this native leaflet, and then on the right-hand side, the aortic wall as well. And we were able to study what goes on in this space. How does that change washout? What are the pathological processes going on here? How might that potentially impact the transcatheter valve? And what we found is that thrombus, halt, calcification, and fibrosis come into play here, similar to what we talk about imaging on transcatheter valves. And that over time, there's a progressive accumulation of thrombus, organization of these thrombus, formation of microvessels, fibrotic tissue, and eventual calcification that occurs in this neosinus, similar to what continues to go on in the native valve. And when we look specifically at the native valve post-TAVR, we see that it becomes very, it starts to crumble, becomes more calcific, it loses cellularity, and really this becomes a very diseased, continually diseased tissue that's sitting right beside the transcatheter valve. So now when we understand this, the next step will be to look at what is the change in washout, what are some of the inflammatory things that go on, something that relates to how we're going to image this. And we need to understand that as we move forward in advancing CT imaging post-implant. One thing we do know that we can image well on these valves is calcification, but probably not in a granular enough a fashion clinically to really inform some of our understanding of degeneration. And so that's something we've also wanted to look at to understand calcification and the spectrum of valve dysfunction. And so we did this in a cohort of valves derived from the explant registry here, in which we looked at calcification patterns on micro-CT of these valves. What we did is micro-CT of all these valves, looking at the distribution. These are generally shorter time period, average median time of just over 3 years. While that seems short on the bench, that's actually probably one of the longest time frames we've seen. It's very difficult to collect a lot of long-term explants, although most of them are from structural valve deterioration causing restenosis. And then we looked at what is actually happening on these valves and mapped this out relative to the pre-explant gradient, but also the gradient in the tester, finding that we can actually break this down by platform, finding that from an initial small cohort that there may be some differences between core valve evolute and sapien, finding mostly that we see more evenly distributed calcium peripherally on the sides versus in the center of the leaflet of sapien. Something we'll need to understand how this may relate to flow dynamics in these different valves as we move forward. But what we do know is this also tells us that calcification is both on the outflow and inflow aspects of these valves. It is also on the leaflet and also intrinsic to the leaflet. Something I think our current availability of imaging clinically isn't able to tell us, but is important to consider, and we'll talk about that briefly in a minute as well. It's why we think this is important to understand. What was the last interesting part of this study is to understand how calcification or non-calcific leaflet thickening contributes to hydrodynamic function. So on the left, you're seeing sequential videos of these explants in a hydrodynamic tester where we can assess EOA, GOA, opening indexes, and gradient regurgitant fraction, and relating that to calcific volume. And what we see is that actual gradient doesn't correlate very well to calcific volume, is that other factors, thrombus formation, fibrosis that we just talked about, and then eventual calcification are all factors that drive the gradient across these valves. So simple calcific volume isn't enough to really understand what's going on in these valves. And really telling us that when we look at calcification, we find that this is really a very heterogeneous process that we need to consider in the context of what else is going on that leaflet in terms of thrombus and fibrotic infiltration, and that we can start to see that there may be differences in platform, but it also tells us that we need to consider what this may have to do with reintervention as well, or leaflet modification. And so I want to talk about that next, but I would slightly point out, probably beyond the scope of this, is that we also talk a lot lately about tricuspid and pulmonic and mitral explants, and that there are very few reports of this, but is going to be a very different process to start to study, and something we'll have to pay attention to as these technologies advance. But I just wanted to close with a couple minutes of looking at, we just talked about how valves fail and what the pathologies are that drive these types of structural valve deterioration and dysfunction of these valves. But really the question we get most of the time is, if we can't inhibit it and this is going to happen, what are the factors that I need to consider if I'm going to reintervene? And people like to ask about, what if I'm going to fracture that degenerated valve? What I need to think about if I'm going to modify that leaflet? And in TAV and TAV, what are the things I need to think about? And then briefly mention, if I'm going to explant, what are some of the things I need to think about? And can I image any of that? So I'll just briefly touch on valve fracture. This is a brief report that we did that we're following up with a larger cohort of valves, where we asked the question of, if you fracture a freshly explanted valve, these were done in the OR approximately 2 minutes after explant in a fracture chamber using a true balloon, asking what actual debris will this generate if I fracture this. We looked at two different styles of valves, obviously externally mounted MitraFlow and internally mounted Magna-Ease, obviously both pericardial, but one having a lot more extrinsic calcification, one having a lot more fibrosis and intrinsic calcification, and looking at how much debris you get off and what is the nature of that debris. And I think the interesting thing to point out here is that obviously we get calcium fragments, but we are also getting fragments of leaflet, we get fragments of thrombus, we get fragments of fibrosis. And really to understand now, what is the risk of this, and are there different types of degeneration that may cause this, and what are some of the ways we can mitigate this? But just showing that pathology does matter in this context. You can also flip that question and say, if I fracture, what pathology am I creating? And so this is, I'll go through briefly for time, but a bench study where we looked at, should you fracture before or after implant of transcatheter valve? We did that using both SAPIEN and Accurate platforms, and obviously showed hydrodynamically that fracturing after THV implant created better hemodynamics on the bench. But what we were most interested in is, what pathology does that actual clinical procedural choice cause to the valve, and what is that potentially causing on the valve? And so we did this by running these valves to 200 million cycles, the equivalent of 5 years, and then looking at what actually happened on the valve. And just to summarize this briefly, what we do find is that when you fracture after, you do cause more damage to the surface of the transcatheter valve than if you don't fracture or you fracture before. And however, after 200 million cycles, if you fracture after, that leaflet is much more maintained. You can tell that the leaflet on the bottom right has not broken down. The valve on the top is very broken down and degenerated. We get a similar image if we fracture before or after. And really all that breakdown is a nidus for activating platelets, inflammatory infiltrates, calcification deposition. And so we really flipped that question on its head. And something we need to understand, what are we doing to these valves that may cause pathology as well? So that's a bit about valve fracture. I'll briefly touch on leaflet modification. Obviously, there are various ways to do this. On the bench, we've considered standard basilica approaches using a blade, such as a shortcut device, and then disruption of the leaflet that may cause coronary obstruction using balloons, whatever you'd like to call that procedure, unicorn, Batman, sleeve, and really understanding how pathology may impact that. An example of that is this, a heavily calcified valve that you may want to modify using mechanical laceration, or you may want to electrosurgically lacerate that and look at the differences in cut. And what we continue to work on is looking at what is the liberation of debris following either one of these procedures, and then what is the actual cut to the leaflet actually look like. And so seeing if there's a difference in that. And one thing we have learned, published recently with Mark Krishwani's group, is in the setting of cleave procedures or unicorn, that calcium will really change the tearing of that leaflet, and something we need to understand more about. So obviously an area of much further study is needed, but really an area where we know that degeneration of these leaflets is going to cause a distinct change to what happens here. And so then finally, the question we get asked most frequently is, does the degenerative state of the index TAVR valve impact my choice on doing TAV and TAV, and what are some of the factors that we need to consider? And we really started to ask ourselves this question after we did this paper that one of our fellows, Miriam Akadad, did with us, looking at where you should implant a sapien in evolute, looking at changes if you implant at node 4, 5, or 6. And that paper really focused on what was the degree of leaflet overhang, what was the impact on sapien expansion, what was the resulting impact on regurgitation and gradient, and really guiding that look at this. The key criticism of this paper is it is done in pristine evolute valves on the bench, as most bench studies are done. And so we wanted to repeat this study using degenerative evolute valves, and to see what we find that is different, to understand how calcification of these valves really impacts the decision to place a sapien in this type of degenerative valve. And so this is valves from the explanted valve registry and from Medtronic themselves that were selected because they were all stenotic on the bench. You can see that here on these videos. They all have some degree of really restricted opening. They have a mean gradient in the tester ranging from low 30s to over 70. Those gradients were consistent with echo done prior to explant. And then when you map the calcium on these valves using micro-CT, you can see they had varying degrees and distribution of calcification. And so really the question then became, do we get a different result if we put a sapien in here versus if we were to use a brand new evolute valve? And so that's what we did. We implanted sapien 3 devices in each of these calcified evolutes. You can see the videos up top, and assessed EOA, mean gradient, velocity, and regurgitation fraction. All but one of these data points falls within the ISO accepted standard, where the regurgitant fraction for a 29 and a 34 evolute was higher. That was consistent with Miriam's initial bench test using new evolutes, where that regurgitant fraction was higher than ISO accepted standard. But I would also argue that our gradient 28 post S3 in a 23 evolute R is not really an acceptable number either. And so really we want to understand what's going on here in terms of not getting optimal results. And so we did that by looking at the positioning of these sapiens, their expansion, and the degree of leaflet overhang. And one of the key things that was different than our initial bench test is the calcification on these leaflets really caused the leaflet overhang to be very stable throughout the cardiac cycle. So the difference of leaflet overhang between systole and diastole was minimal. Less than 10% in all cases, in most cases, in 2 of the 4 cases, very small, below 2%. But what we do see is that actually creates a geometric orifice area that is still sufficient. So meaning that geometric orifice area is larger than the effective geometric orifice area of the sapien that's been implanted, showing us that we get good flow out of that sapien. What we don't know is how that affects flow, and something that needs to be studied in the future using different techniques, certainly. What we do know is that the result of this is because that sapien is underexpanded. Here we can see that pattern of calcification is causing really an underexpansion of that sapien in various patterns, and is related to the distribution of calcification on that failed evolute leaflet. And finally, what we noticed is that while that leaflet overhang was stable, and while we could model coronary access on the bench, when we're watching these videos and trying to do these cannulations, what we do see is that we get calcium protrusion of the degenerated evolute leaflet through, and it's contacting the actual sapien leaflet. And if you remember when I showed our calcification mapping, I said, the fact that there's calcification on both inflow and outflow aspects of the valve, and it's both intrinsic to the leaflet and extrinsic to the leaflet, will become important. This is where this becomes important. So repeatedly, we're seeing that sapien leaflet make contact with this nodular sharp calcium, something that we don't know the durability of, certainly at this point. And is another example of where we need to understand degeneration of these leaflets and its implication for long-term durability of a second valve. And really, that comes into play in other aspects as well. This is some surgical valves where we looked at distribution of calcium on these inflow and look at how that would impact expansion of a sapien or evolute, and also the contact that would occur between the degenerative calcific leaflets and the newly implanted THV for a valve-in-valve procedure opposed to tap and tap. And so really that concept is this concept of, well, we often talk about stent ID and true ID. We also need to consider how the pathology of these valves changes that and where that impacts a second valve. And so the concept of that will narrow the actual landing zone, and also you will have interaction of the pathology of these valves with that second valve as well. Similar to when we consider native valves interacting with an index TAVR valve as well, telling us that pathology really affects THVs across the spectrum from initial implant to implant of a second, or in some cases even a third valve, which we're seeing explants of TAV and TAV and TAV now as well. And so overall, I hope that I was able to convey to you that THV durability and degeneration are complex mechanical and biological processes that are still in the process of being characterized and require multi-center registries of these valves and detailed histological analysis. We talked about how thrombus impacts leaflet durability and function, and how that is related to progressive pathology of fibrosis and calcification. In most cases, we showed that PET related to platelet activation and calcification are emerging methods to better understand the biological processes. I would also note that there are people working on fibrosis tracers that allow us to look at that intermediate fibrotic stage of these valves as well. And that programs like mine use bench testing of THVs to provide new insights to new platforms of valves, but also trying to model these situations and understanding interaction of biological, mechanical, and procedural factors. And really that allows us to really refine bench analyses and try to make them as clinically applicable as possible to provide new insights to operators and imagers. And I would then be remiss in saying that we are unable to do this work alone, that this is very dependent on the entire valve and imaging, cardiac imaging program support here at St. Paul's and Vancouver General, and that all of the sites that go through the process with us of being part of the explanted valve registry are invaluable to us. And really the data you've seen today is a result of their collaboration and partnership on this. So thank you so much to everyone, and happy to take questions, but hopefully that gave you a brief overview of some of what we did and answered some of your questions related to valve degeneration and durability.